So, a very good morning to all of you. Second case presentation which I am presenting is endocrine manifestations of systemic diseases, a case series based insights into complex interactions. I'm Dr. Devyam Suri from Kasturba Medical College. So, introduction, systemic diseases often manifest with atypical clinical features which can be beyond the primary organ involvement, like these may, though significant, may go under recognized also. They may precede, coincide, or follow with the diagnosis of the primary cystic illness. So, understanding the pathophysiology of underlying endocrine involvement in these diseases is critical for early recognition, appropriate diagnostic evaluation, and targeted strategies to mitigate morbidity and improve long-term outcomes. So the aims of this case series presentation is to illustrate varied endocrine complications secondary to systemic diseases, thereby promoting early identification, which is depicted via these 4 case series. Among materials and methods, first case series was Edinson crisis, which was noted in a patient of rheumatoid arthritis, where a female 58-year-old female, which was already seropositive RI, diagnosed 8 years back, was already on methotrexate, hydroxychloroquine, and prednisolone 5 mg per day for the past 2 years, has presented to us with high-grade fever, vomiting, worsening joint pains since last 4 days, and given a history of 5 days back, she has suddenly actually stopped her medication due to persistent nausea and vomiting. On examination, she had tachycardia as well as hypertension was present, and active synovitis was noted as the DAS score was about 3.5. So initial lab showed neutrophilic leukocytosis, elevated CRP, indicated infection, hyponatremia of about 130, only borderline hyperkalemia of about 5.1, and hypoglycemia, that is 88 sugars. Hence, Edinson crisis was suspected in her, and a relevant investigation, that is cortisol and ACTH, was sent, which came both low. Urine suggestive UTI. So initially, because she came in a crisis situation, she was initially stabilized with IV hydrocortisone 100 mg stat followed by 50 mg 6th and other supportive management with fluids, noradrenaline, and empirically was started on piperacillin and tazobactam. Later, it was optimized as per the culture reports, which showed E. coli, which was sensitive, hence was continued on same antibiotics. Serial monitoring of electrolytes was done. Once she was stabilized, the hydrocortisone was tapered and was transitioned to oral prednisolone and oral fluticort. Methotrexate was initially withheld, which was later restarted. However, patient was planned for ACTH stimulation test on follow-up basis, which also showed low cortisol levels on ACTH stimulation. This photo depicts the various deformities which were present in the patient of rheumatoid arthritis. So via this case series, my key message is that importance of recognizing Edinson crisis in patient with chronic steroids, especially when steroids are abruptly stopped, which occurs because there is a chronic suppression of an HPA axis. Second is bronze diabetes, which is noted in thalassemia major patient. Here, patient who is transfusion dependent beta thalassemia major came with progressive fatigue and 5 to 6 kg weight loss over 3 months. He has been on regular blood transfusions since receiving monthly. On examination, he revealed pallor, mild icterus, and skin hyperpigmentation, which can be seen over the knuckles, and hepatosmegalomegaly was noted. Initial lab showed anemia with raised serum ferritin of 2150, high iron of 200, and transferrin saturation of 71%. Blood sugars were about 186 with an HbA1c of 6.8. Hence, initial suspicion of secondary hemochromatosis was suspected, and patient was transferred with 2 PRBCs and was started on desferoxamine infusion. Other photo depicts a typical thalassemic face is seen in that patient. So subsequent imaging showed normal C-peptide levels, and T2 star MRI was done, which showed heart was normal, but liver MRI showed hypotensive signals, which was consistent with iron overload. Hence, management was done, chelation was intensified, and defacerox dose was increased to 1000 mg per day. The patient was started on basal bolus insulin regimen during the hospital stay, and later was discharged on metformin, defacerox, and folic acid. Key message via this presentation is importance of early recognition and management of iron overload in transfusion beta thalassemia patient to prevent complications such as secondary diabetes, which was seen in this patient. Third is SIDH in tubercular meningitis. Here, a patient who is 32-year-old female which came with fever, hemiparesis, and altered sensorium since last 2 days, weight loss since about 1 kg. There was no significant drug history noted. On examination, she was drowsy, had left-sided hemiparesis, left human facial palsy was present. Initial labs MRI showed acute infarcts as well as on a vessel MRI showed circumferential wall thickening suggestive of vasculitis. Hence, in view of prodromal symptoms as well as subacute history and meningovasculitic picture, TB meningitis was suspected, and CSF finding was done which showed lymphocytic pleocytosis and high protein. Main key thing which we noted was hyponatremia, which is 123 in her. So provisionally was diagnosed as a TB meningitis with hyponatremia, suspected SIDH in view of clinical euvolemic status in her. Lab workup is sent which showed low serum osmolarity, high urine osmolarity and high urinary sodium suggestive of SIDH. Hence was managed initially with 3% NaCl, fluid restriction and extra salt diet. Gradual improvement in sodium and sensorium occurred. Patient was also started on ETD as well as simultaneously on steroids, that is dexamethasone 6 mg TID. Other was hypercalcemia with unwheeling sarcoidosis. A 42-year-old male present with generalized fatigue and dry cough and weight loss. He was dehydrated on examination and had tachycardia. Initial lab showed anemia with high serum calcium of 11.9, low phosphate and low PTH. Chest X-ray was shown as bilateral hilar lymphadenopathy. In view of hypercalcemia as an acute emergency, he was managed with hydration with IV normal saline and subcutaneous calcitonin. Subsequent imaging showed serum ACE levels were high, 101, as well as 24-hour urine calcium was high. HRCT was done which showed perilymphatic ground glass nodules, and transbronchial biopsy was done which showed granulomatous inflammation to rule out TB, which came negative on MTB quantiferon test. Hence clinical radiological diagnosis was thought of pulmonary sarcoidosis with hypercalcemia. Patient was finally started on oral prednisolone 30 mg per day, and reduction in serum calcium was noted on day 4, which reduced to 11.1. So plan was to continue steroids with tapering over 3 weeks. Take home message is that in patients who come with non-PTH mediated hyperglycemia, causes such as granulomatous disease like sarcoidosis must be considered. Discussion wise, these case series highlights how systemic disease can cause diverse endocrine abnormalities such as sarcoidosis causing hypercalcemia due to excess vitamin D activation, while iron overload was seen in thalassemia due to secondary diabetes, and prolonged steroid induce can cause adrenal insufficiency upon sudden withdrawal, and SIDH association seen in CNS infections. Conclusion wise, early recognition targeted therapy can significantly alter disease trajectory and improve outcomes. Clinician must maintain an high index of suspicion and remain vigilant for such manifestations. Thank you.
Good cases, Divya. One question regarding the terminology Addisonian.
Yes.
Do you prefer Addisonian here or something else?
Adrenal insufficiencies.
One thing is that Addisonian should be reserved for primary adrenal insufficiency related crisis, because Addison disease is primary adrenal insufficiency.
Yes,
so here you're probably dealing with a tertiary or secondary, you can say. So it's better to reserve the terminology to adrenal crisis rather than Addisonian crisis. And regarding the biochemical profile, you mentioned low sodium and high potassium.
Yes,
is it common in secondary adrenal insufficiency? How will you explain that?
So
and just let me know the mechanism of hyponatremia in primary and secondary adrenal insufficiency.
So hyponatremia and hyperkalemia actually are more commonly seen in primary adrenal insufficiency as compared to secondary. In this patient, he had only had borderline hyperkalemia, because mechanism behind that, in this secondary adrenal insufficiency, RAS system is spared, because aldosterone is not dependent on ACTH. So the electrolyte abnormalities are not much seen as compared to a primary adrenal insufficiency patient.
How hyponatremia occurs in secondary adrenal insufficiency?
So due to deficiency of cortisol cause
it leads to actually free water excretion.
Yes, free water
cortisol actually leads to free water excretion. When there is a cortisol deficiency, it will lead to free water retention, just like it mimics euvodemic hyponatremia like SADH. So that's the mechanism. There is no aldosterone axis involved in secondary adrenal insufficiency or tertiary. So usually you will not see hyperkalemia. So you need to look out for the cause of hyperkalemia in this patient.
Yes. Yes, sir. Ma'am, hypogonadism can be seen in these patients, as well as hypopituitarism has also seen where, because wherever like iron deposition is there, that can cause a decrease in function of those endocrine glands. Theoretically, hypogonadism has been more associated with thalassemia major patients, like, and hypopituitarism also there. Hypothyroid also is. Yeah. Both. Yes.
The first case, doctor asked you about hypokalemia. The patient had prerenal azotemia, hypertension,
Yes.
urinary tract infection. Did you do the blood gas?
Uh,
Like acidosis, elevate the potassium.
yeah, ma'am.
You can explain that case when asked. You would not expect the potassium to be high normal, but in that particular scenario, the patient was hypertensive, a certain level, 90-60.
Yes, ma'am. Patient was hypertensive. He required initially NORAD support also because of hypertension. Initially, yes, ma'am. Initially,
Explain the borderline high potassium in that case.
yes, ma'am. As well as that potassium was only, that creatinine was initially suggestive of acute kidney injury because it resolved by giving fluid support and NORAD support. Initial ABG also showed lactates was initially high, which also reduced to on giving fluid support. It also came down, ma'am, in that patient.
Third case you mentioned sarcoid. What is more common in sarcoid, hypercalcemia or hypercalciuria? Can you tell me? And is it common? How common is it in tuberculosis?
Uh, Ma'am, tuberculosis wise, hypercalcemia was seen in sarcoidosis patient, ma'am. TB patient had SIDH actually. Mainly theoretically, we don't see SIDH. SIDH can be associated with CNS infection, but one more DD we should keep in our mind is cerebral salt wasting syndrome in him. Because the patient had clinically euvolemic status as well as there was no history of any polyuria in him, and lactates were also not much high due to dehydration. There was clinically euvolemic status, hence we. Uh, Ma'am, it is due to secretion of 1-alpha hydroxylase from the tumor cells or from the granulomatous tissue, ma'am. Which. Yes, ma'am.